Hi and welcome back to another video of Medic Notes. This video is on disseminated intravascular coagulation. Disseminated intravascular coagulation is a condition in which blood clots form throughout the body, blocking small blood vessels. Symptoms may include chest pain, shortness of breath, leg pain, problems speaking, or problems moving parts of the body. As clotting factors and platelets are used up, bleeding may occur. This may include blood in the urine, blood in the stool, or bleeding into the skin. Complications may include organ failure. For etiology, this condition usually results from exposure of tissue factor to blood, initiating the extrinsic coagulation cascade. In addition, the fibrinolytic pathway is activated in DIVC. Stimulation of endothelial cells by cytokines and perturbed microvascular blood flow causes the release of tissue plasminogen activator from endothelial cells. Both TPA and plasminogen attach to fibrin polymers, and plasmin generated by TPA cleavage of plasminogen cleaves fibrin into D-dimers and other fibrin degradation products. DIVC can therefore cause both thrombosis and bleeding if the consumption of platelets and coagulation factors is excessive. DIVC occurs most often in the following clinical circumstances. Complications of obstetrics, such as in abruptio placentae, saline-induced therapeutic abortion, retained dead fetus or products of conception, and amniotic fluid embolism. Placental tissue with tissue factor activity enters or is exposed to the maternal circulation. Other conditions are infection, particularly with gram-negative organisms. Because gram-negative endotoxin causes exposure or activation of tissue factor activity in phagocytic, endothelial, and tissue cells. Cancer, particularly adenocarcinomas of the pancreas, stomach, biliary tract, lung, prostate, or breast, and acute promyelocytic leukemia, where tumor cells express and expose tissue factor. Shock due to any condition, which causes ischemic tissue injury and exposure or release of tissue factor. Other less common causes include severe tissue damage due to head trauma, burns, frostbite, or gunshot wounds. Complications of prostate surgery that allow prostatic material with tissue factor activity to enter the circulation. Enzymes in certain snake venoms that enter the circulation. Profound intravascular hemolysis, most often during acute hemolytic transfusion reactions due to ABO incompatibility. Aortic aneurysms are cavernous hemangiomas with vessel wall damage and areas of blood stasis. Slowly evolving disseminated intravascular coagulation typically results mainly from cancer, aneurysms, or cavernous hemangiomas. For the pathophysiology, slowly evolving DIVC primarily causes venous thromboembolic manifestations, like deep venous thrombosis and pulmonary embolism, although occasionally cardiac valve vegetations or arterial thromboembolism occur, and bleeding is uncommon. Whereas for severe, rapidly evolving DIVC, in contrast, causes thrombocytopenia, depletion of plasma coagulation factors and fibrinogen, and bleeding. Bleeding into organs, along with microvascular thromboses, may cause dysfunction and failure in multiple organs. Delayed dissolution of fibrin polymers by fibrinolysis may result in the mechanical disruption of red blood cells, producing schistocytes and mild intravascular hemolysis. Signs and symptoms include symptoms of venous thrombosis and symptoms of pulmonary embolism. In severe cases, there may be persistent bleeding or formation of ecchymoses. Investigations include platelet count, prothrombin time, partial thromboplastin time APTT, plasma fibrinogen, and plasma D-dimer. For diagnosis, slowly evolving DIVC produces mild thrombocytopenia, normal to minimally prolonged PT and PTT, normal or moderately reduced fibrinogen level, increased plasma D-dimer level. Because various disorders stimulate increased synthesis of fibrinogen as an acute phase reactant, a declining fibrinogen level on 2 consecutive measurements can help make the diagnosis of DIVC. Initial PTT values in slowly evolving DIVC may actually be shorter than normal, probably because of the presence of activated coagulation factors in the plasma. Rapidly evolving DIVC results in more severe thrombocytopenia, more prolonged PT and PTT, rapidly declining plasma fibrinogen level, and high plasma D-dimer level. Measuring factor VIII levels can sometimes be helpful if severe. Acute DIVC must be differentiated from severe liver disease, which can cause similar laboratory findings. Because factor VIII is not synthesized by the hepatocyte, factor VIII levels tend to be normal or even high in liver disease. In contrast, all coagulation factors are consumed during DIVC, so factor VIII levels are typically reduced. D-dimer levels also tend to be higher in DIVC than in liver disease. For treatment, treat the cause, replacement therapy such as platelets, cryoprecipitate, or FFP. Antibiotic treatment of suspected gram-negative sepsis. Evacuation of uterus in abruptio placenta. Blood volume repletion in bleeding cases. In cases of severe bleeding, surgery may be indicated, together with replacement of platelet concentrates to correct thrombocytopenia. Cryoprecipitate to replace fibrinogen, and FFP to increase levels of clotting factors and natural anticoagulants. Blood volume repletion if there is hypotension. Heparin usually is not indicated in rapidly evolving DIC with bleeding. Heparin is usually more useful in treatment of slowly evolving disseminated intravascular coagulation with venous or arterial thrombosis. Although heparin usually is not indicated in rapidly evolving DIC with bleeding or bleeding risk, it is indicated in women with a retained dead fetus and evolving DIC with a progressive decrease in platelets, fibrinogen, and coagulation factors. In these patients, heparin is given for several days to control DIC, increase fibrinogen and platelet levels, and decrease excessive coagulation factor consumption. Heparin is then stopped and the uterus evacuated. Heparin can also be useful in controlling the chronic DIC associated with aneurysms, resulting in an increase in fibrinogen and platelets. Some key points from this video. In disseminated intravascular coagulation, coagulation is usually activated when blood is exposed to tissue factor. In association with coagulation, the fibrinolytic pathway is also activated. DIC usually begins rapidly and causes bleeding and microvascular occlusion, leading to organ failure. DIC sometimes begins slowly and causes thromboembolic phenomena rather than bleeding. Severe, rapid-onset DIC causes severe thrombocytopenia, prolonged prothrombin time and partial thromboplastin time, a rapidly declining plasma fibrinogen level, and a high plasma D-dimer level. Immediate correction of the cause is the priority. Severe bleeding may also require replacement therapy with platelets, cryoprecipitate containing fibrinogen, and fresh frozen plasma containing other coagulation factors. Heparin is useful in slow-onset DIC, but rarely in DIC of rapid onset. That's all for this video. Thank you.